Sandy has asked me to look at the state of HIV prevention, which is an onerous task, especially for somebody who is now doing medical microbiology. So bear with me, but we'll go through and just see where we are insofar as HIV prevention is concerned. And I thought what I will do, in fact, I was just telling Steve that I'm probably going to be all over, but at the end of the day, we will get a few things across. So I thought where I will start will be to just look at, just a review of the epidemic, where we come from, and just look at, some of the high-risk populations, what are the prevention opportunities that are there, and what are the efficacy trials that have been, where are we insofar as trials are concerned, and then some of the challenges that we face. Now, when we're reviewing the epidemic, I could not but, look at this. I don't know how many of you are on Facebook. I am. So, in the last few days, for some reason, and I'm still trying to understand where this is coming from, our past president has actually written some comments, and reflecting, from the past. And I'm struggling to understand why is he doing this now and what is he trying to correct? Because, for me, it looks like he's actually just sinking himself even deeper. Whereas as a country, I think we had already moved and we sort of had forgotten about that. And now we're looking at the positives. So when I'm reviewing the epidemic, I'm hoping that this is rather to actually look where we have come from, but at the same time, how much we have achieved. More than, whatever mistakes and errors that were made, which cannot be, once you make an error, unfortunately, you can't do anything about it. It's in the past. You just need to see how do you move from that point forward. So, when I was a registrar in medical micro, that was, in the 80s, I remember this so well that we used, the head of virology then was Professor Smith, and what he used to do is that we would actually look at antenatal, anonymous, antenatal screening. We would do this, every year, and this was before anybody was talking about HIV, and he would do this anonymous testing. I remember the first year that he did it, in whatever month that he chose, and we were sitting at probably the first one would have been close to 0, and then the next year it was 0.1, then it was 0.4, then it was 1.2, and then we started getting worried and we said, there's something happening here. And, and we really couldn't explain what was happening, but we could see that, we were going to face, a huge epidemic if we don't do anything. And lo and behold, we obviously did not do anything, especially in our country. And, this just shows, from the early 80s when the virus was discovered, just, how it spread, and it actually spread throughout the world. And we know the history that, as Sub-Saharan Africa, we were the most hit, countries, and we have remained so. And obviously, if we had done something then, probably you would not be where we are today. But that has been done. That's water under the bridge. We can't change that now. But also, if this just shows, the number of people with HIV, in the early 2000, 1990, 95, 2000, and number of deaths. And this was happening throughout the world. But we all know that something happened, around 2005, and we know exactly what that happened. That was the introduction of antiretroviral therapy. In fact, this coincided with the introduction of PIs when protease inhibitors came, into the picture, and this was seen, in the countries that were using antiretroviral therapy, that the deaths definitely decreased, but obviously, the number of people living with HIV, continued to increase. Now, this happened in the developed countries, and obviously not in Sub-Saharan Africa. But our death rates continued to rise until quite recently, actually. I so remember, a period in our life where we stopped, well, not stopped, we continued with our weekend funerals, but there were funerals throughout the week as well, because we're burying families, friends, colleagues, and it was at the peak of the epidemic. So we really have come a long way. And then, then there was progress, because I think everybody realized that we had an epidemic, a global epidemic in our hands. And one of the first things that have happened was actually to look at infections in children. And when the drugs became available and then were used for prevention of mother-to-child transmission, we then saw definite reductions, especially, if looking at this, between 2009 and 2012 alone, we managed a 40% reduction. And this, for us as a country, right now, it actually is probably one of the, the best achievements that we have seen in the HIV epidemic. That we managed as a country, when the introduction of PMTCT came in, with all the training that came in. Yesterday, actually, we were talking about this, Steve, you're going to be touching on it, how much the nurses actually end up carrying the burden. And, because when then PMTCT came, there was this massive training and rollout of PMTCT. And lo and behold, we have seen the impact thereof. And we have seen the fact that now we've managed to reduce, mother-to-child transmission to, around 1%. So that's a huge positive for us insofar as, prevention and transmission of HIV. And we continue to do that. Now, the problem that we have had has obviously been the fact that, because if you want to make any impact on the epidemic, we know that once somebody is HIV infected, they are infected for life. We keep them, to live longer with antiretroviral therapy, but they are going to remain in the infected pool. So if we want to make any impact on the epidemic, what we need to really be targeting on is making sure that there are no new infections. For as long as there are new infections, we have not controlled the epidemic. And unfortunately, I really wouldn't say we have won insofar as that battle is concerned. Yes, for neonatal infections we have, in that we hardly see neonatal, HIV infection. But for the adult population, that is the biggest challenge. So if you're looking at the number of new infections, in sub-Saharan Africa, even though there's a decrease, but it really is still unacceptable. And in fact, when I just look at where we are as a country and the number of new infections that we have, even though it's not, it seems to be coming down, but it is not coming down as we want to see it. It is not making an impact on the epidemic. So we still have got a long way to go. Now, this is not something to be proud of. When you look at our population, and for us to actually be hosting 18% of all the infections in the country, in the world as a country, that's definitely not something to boast about. But that is where we are, followed by Nigeria. These are just some of the first 10 countries with the highest number of people living with HIV. And you can see that actually these are all African countries except for the US. And even that US, really, if you compare, to their population, and also, I never forget that, and forget this, that actually, when we're talking absolute numbers, it really is nothing, and percentages as well. Because really for the US, I think they only reached 1 million infections, in around 2010, 2011, and so when we're saying they are in the first 10, you mustn't think they are close to us who are sitting at 6 million. So really we're talking, very low. But be that as it may, so in South Africa we've got the highest numbers, and in fact, there's India as well, sorry, there's India as well. And then 33% is actually formed of that, number global is formed by South Africa, Nigeria, and India. So we have got a huge epidemic. And really now, bringing it even closer home, just looking at now the adult prevalence. Now remember, when we're talking prevention, as I have said, prevention is to really make sure that there are no new infections. But otherwise, the pool of infected people, for as long as, for instance, we have got antiretroviral therapy rolled out, that pool is likely to increase because people are going to live longer. So the prevalence will remain, where it is for a while, or even go higher for as long as there are new infections, provided there are no deaths, obviously. So if we're looking at, some of the neighboring countries, Swaziland, this was in 2015, last year. So Swaziland is still ahead, and we're sitting at 18.9, which is almost 20%, which means 1 in 5 South Africans are actually, living with HIV. So, like I have said, there is progress that has been made. PMTCT, I'm going to touch on some of the prevention, modalities that have come through and have been effective. So in 2014, 37 million living with HIV, 2 million new infections, and this is definitely not acceptable. 1.2 million deaths. Now, this is where I wanted us to come to. What about new infections? We still as a country are seeing 1,000 new infections, occurring each day in the country, and that is just not acceptable, which therefore means we've got to really make a difference in our preventive, research. Okay, so where are these infections? Because now everybody talks about the key populations, and we now have sort of defined the epidemic, and we know which populations are hit the most at which parts of the world. And this slide just shows it very well, that actually if you're looking at, let me rather use this. If you're looking at the Americas, both North and South, it's mainly still an epidemic of men who are having sex with men. And if you're looking at Europe up there, it's mainly people who are injecting drugs. So those are the key populations for those countries. And if you're looking at, at the east on that side, it's mainly sex workers. But when you look at where we are, which is, in sub-Saharan Africa, for us, when we're talking key populations, we really need to focus on young women. And we know that young women actually bear the brunt of the epidemic. And so when we're targeting for prevention, it therefore means whatever programs that we have, we've got to look at young women. But, that does not mean we do not have sex workers. It doesn't mean we do not, there's another biggish, circle there for pregnant women. So there are other pockets as well. But really, for all intents and purposes, in our environment, we need to be targeting this, towards young women. Now, when we talk about young women, this just shows, the burden of disease in young women as, compared to their male counterparts. I know Slim and Koresha, they've got this famous slide that they always show, where we know that there's always a 5 to 8 year difference between the ages, between men, boys and girls, where we know that as far as, like I have said, PMTCT is effective and it's got no gender. It is not gender-based. So boys and girls, or that are born to infected mothers, they've got the same prevalence. But the difference happens once, we see, from 4 years to 5-year-olds is the same prevalence. But we begin to see a difference, when the girls then get into their teens, where they shoot up, with the prevalence. And this is what we see throughout the sub-Saharan Africa, where you're seeing that there are more females that are infected, especially in the 15 to 24-year-old compared to men. Now, what are some of the issues that facilitate this infectiousness and susceptibility? So we know that if there's a high concentration level in the blood, which therefore means the viral loads of those that are infected are important, and that's where then, a treatment as prevention comes in, where you then need to make sure that you lower the viral concentration, so that they are less of a risk to transmission. And we know when we get this, for instance, in acute HIV infection, that's where you find your viral loads in millions, which therefore means we've got to be diligent. And if we want to actually prevent HIV, we've got somehow to be diligent and look for acute infections because they are one of the highest risk transmitters, and then the advanced disease. And for advanced diseases, with the rollout of antiretroviral therapy, the majority of patients would be on treatment. In fact, if antiretroviral therapy is effective, we should not be getting AIDS anymore. So we really should not be seeing any advanced diseases, which therefore means we are then faced into looking and making sure that we control acute infections. We know that concomitant and genital tract infections actually increase the risk of transmission. So if we're talking prevention, we therefore need to look at that. How do we control STIs? Because we know that, with STIs, it actually gives you a high risk of transmission. Any other local inflammation, we've shown data that shows that actually with inflammation, the risk of transmission is much higher. So how do we identify, inflammation, especially in young women, and how do we manage that so that it reduces the risk of HIV acquisition? I've already mentioned about, the stage of the HIV disease, concurrent STIs, and then we know that there are certain host and genetic factors that may contribute to susceptibility or infectiousness of people living, with HIV. So, when we look at prevention, I'm going to be then talking about, we know that traditional prevention has always been, let's look at those that are negative and make sure that they remain negative. So we don't want to see new infections. But at the same time, we now know that there's actually a significant impact on slowing the spread of the epidemic. And therefore, if we make sure that those that are infected, they remain at low risk of transmission, that then will prevent, them being high, transmitters. So it's got to be a two-pronged. So where can we, talk prevention? If, for instance, one looks at those that are not exposed, the uninfected, and this is the pool that we want to keep, for as long as we can. So there may be behavioral or structural modalities that we can use. We know that we actually have had, as far as male medical circumcision, we've had success. We had these 3 key trials that showed the impact of male medical circumcision, and we know that that's a modality that works, provided that obviously men present themselves to clinics for circumcision. Condoms, we've been talking condoms as a country forever, for donkey's years. And for me, that's the question that I always ask myself, that really, I'm sure everybody knows that condoms prevent, both STIs and HIV infection, but we have got the highest new infections, which therefore means, even though we've got the knowledge, practice is a different thing. And we have seen this, and this happens every day. Even now, with the results that were published recently, when they looked at condom use is really not where it should be, and yet we all know. So whilst condoms work when used appropriately, but we know for a fact that in practice they do not. But they always, form part of prevention strategies, because when used appropriately, they definitely reduce the risk of transmission. And then, for those that are exposed, those that are sexually active, what more can be done over and above circumcision and condoms than vaccines? And, vaccines, we know, vaccines are the best, they revolutionized infectious diseases, but you've got to find the vaccine, and it must be an effective vaccine, and it must be easy to administer. Now, as far as HIV is concerned and vaccines, we really are still a long way to go. And I'll show you just some of the data of where things are at. So whilst we are all waiting for the vaccine, we don't have that, and we're not going to have it in the next 10 years at least. So we need to find other ways. There's been a lot of interest around, whether it's pre-exposure prophylaxis or post-exposure prophylaxis. And, there's good data that's showing that it works. And I think that's what now everybody is, is focusing on. We just need to identify the populations that should be getting antiretroviral therapy, PrEP or PEP, because we know it works. It just needs to get into, into the appropriate guidelines and policies. Microbicides, there was a time, especially vaginal microbicides, the gel, with the Caprisa 004, when the results came out, we were all excited. It looks like we've got something. Let's do facts 001 to prove it and make sure that, women can have a gel, they can control their lives, they can insert the gel whenever, if they know they're going to have sex, and, we're okay. Unfortunately, when the confirming study was done, it really, it didn't give us exciting results. But we know the reason why. And we know that for as long, which is actually one of the challenges, in my last slide, for as long as whatever prevention method, or any method for that matter, is dependent on the patients or on the participants or on the communities using it. We have seen this with condoms. Condoms prevent HIV, but people don't use it. Even if we can come up and we can show that, tenofovir gel, when used, it actually reduces transmission of HIV, the question is going to be, are people going to use it or not? So whatever modality that we come up with, we need to take the human element away from it, which is why vaccines just make sense. Because for me, even actually the oral PrEP and PEP, patients or people have got to take it for it to work. So if they don't take it, it's not going to work. So these are just some of the challenges that are facing us as we talk, HIV prevention. So, and then the big one now, which, people have shifted into, like I have said, if you are HIV infected, you've got a high viral load. We know that you're a high you are at a risk of transmission. So if you can reduce the viral load and you end up with, viral suppression, then the transmission rates are much lower. And that's why there's a big focus now. Let's not just look at those that are negative, but let's make sure that we treat the ones that are positive and we treat them, effectively. This is probably a busy slide, but it just shows you, some of the microbicide trials that have happened. I know in the microbicide field, there has been too many disappointments. Starting from way, in 2000, there really had not been any of the products that, got people excited in any way until we got to Caprisa 004, like I said, and this was in 2010, where, it showed efficacy of 39%. And when, further analysis was done on that trial, we could see that for women who are adherent, who adherently use the gel, actually that 39% increased to above 50%. So if you use the gel, it will protect you. But the question is just that, as I have already mentioned, that people tend not to use these things. Now, there has been, and I know there's an ongoing, yes, I've talked about FACS 001, which was supposed to prove 004. And what we have seen is that really, unfortunately, women did not use, they were not adherent to the gel. As a result, we didn't get the results that we had. So this sort of, leaves the whole, tenofovir gel hanging. Because now, unless they take the gel, only then will it be effective. So there's a lot, of excitement now in that the, dapivirine ring and the ring study results have just come out, and I'm going to tell you the results just now. I mean, those two studies. This is now a vaginal ring that's impregnated with an antiretroviral drug, and those two trials have shown efficacy. Even though, the one, is sitting about 27 and 31%, but the good thing is that when they then looked at the women who used the gel, they saw that actually those that used the gel, the efficacy, rates were much higher, and there's a big challenge with younger women in that for women who are 21 years and older, the efficacy is much better, and I'll get to that just now. And these are some of the challenges as we, go through the prevention, science, and what are some of the challenges, and how do we ensure that we overcome those? And what's on the pipeline? So the idea here, because we have seen that if it's a gel that's going to be coitally dependent, firstly, we're looking at young girls, as I've mentioned. Firstly, most women, they don't know when they're going to have sex. And so to actually put the gel in advance in anticipation of sex, whether that's feasible or that's practical is one story. And the second question becomes, are they therefore going to use it and use it appropriately or not? So, which therefore means any coitally dependent mechanism of prevention has got a lot of challenges. And that's why people are moving into using rings that can be inserted into the vagina and can stay there for instance, the vaginal rings that have been used, they can be changed every 4 weeks. So it would really just be like, sort of like contraceptives in a way. And I know for a fact that actually people are looking at not just using it to prevent HIV infection, but like it says here, a multi-purpose prevention technology where you include contraception, protection against HIV, and against other STIs. This really would be what would be ideal, where a woman knows they're going to the clinic, they get this, and the good thing is that these rings, you can actually insert it yourself. I'm not sure if that's a good thing or a bad thing, because the fact that you can insert it yourself, it means you can take it out as well. And I think actually some of the results that we have seen recently prove that. So maybe, we probably need to give them rings that once inserted, like Depo or like, an implant, once it is there, they can't take it out, especially in the younger age group. And then, okay, so that's microbicides. The big issue with HIV vaccines, as I've said, we know that actually vaccines, if we can get an HIV vaccine, that is going to answer a lot of challenges, a lot of our problems. But it has been a very difficult path in that, you and me, we know, when the initial trials that went, out into the field, everybody was hopeful, but actually the first trials that were looking at the envelope, part of the virus, there was no efficacy whatsoever. And in fact, then everybody moved on to cell-mediated induced, responses. And we hope that, something was going to come out of that. And then that as well yielded no results at all. The only glimpse of hope was really with the Thai trial. And everybody is just focusing on that because for the first time, we were able to demonstrate that actually a vaccine could be used and it could have some, even though very limited, efficacy. In that, for instance, the RV144 trial showed 31%, efficacy. That's not a big, that's not big, but it actually explains and it tells us that it can be done. And it has actually allowed the science to grow even further in trying to understand how did those patients that were protected, what were some of the immune responses and what can we learn from that and how can we therefore improve on the next generation of vaccines that we have. And then, so we don't have a vaccine against HIV because really we don't understand the the correlates of protection. We haven't seen anybody who has been infected who has managed to control the infection and clear the infection. There has been no natural, immunity from the virus. And so we don't really understand. As a result, when we're designing a vaccine, what are we fashioning it after? We don't really know. And that really what has been giving, HIV scientists sleepless nights over all these years. And the second thing as well is that the virus, because it rapidly, it actually replicates so rapidly and it mutates and as a result escapes the immune system. So it's a rapidly moving target and all the time it's able to actually evade the immune system. And so when we're creating a vaccine, how then do we make sure that that vaccine is going to overcome that? And also we know that it gets integrated into the human DNA. The biggest challenge as well is that the antibodies that are produced by everybody who's otherwise HIV infected, most of those, in fact, until quite late in their infections, they are not neutralizing antibodies. So we only see neutralizing antibodies much later in the infections, beyond 3 years of infection. So how then, then it becomes difficult to deal with that. So there's still a long way. But people are beginning to say, okay, we've seen progress on other prevention modalities. So do we still need a vaccine or not? And I think I've made a good case that, even though treatment as prevention works, even though circumcision works, even though condoms when used work, even though, all the other modalities of treatment work, for as long as they are still dependent on the patient or on the participant inserting or going for maybe circumcision is better because they just go once, but otherwise we need a vaccine that's going to be given once and that's going to protect for a lifetime. That's probably too ambitious, but it's not impossible. And it must give durable protection, and it must actually be amongst we know that an effective vaccine is the most cost-effective medical intervention. So this is some of the work that's happening in the vaccine world, in that they have now formed this pox protein public-private partnership, and that's looking at building on the RV144 to understand the science and to see, whether we can, the scientists can come up with better constructs that go into vaccine development. And these are some of the timelines, of what's to happen next. And you can see that we still are going to be, a long way, as I say, insofar as the HIV vaccine is concerned. But the momentum is there. And I think, especially recently with the broadly neutralizing antibodies that have been recently discovered, there's a lot of excitement, because then it looks like there are certain, those can be used in actually, forming the vaccine as parts of the vaccine components. So, okay, now this slide just takes us through all the trials that have really been, done in HIV prevention. And, microbicides, I don't know why it keeps moving. Microbicides, you can see that really there has not, there has been no joy whatsoever. The first where we saw a glimpse, okay, now the thing here is that this actually includes the recent results of the RING study and the ASPIRE studies that contain dapivirine. So you can see that now we have increased, studies that have been positive, in that have shown efficacy. In that, if you're looking at the ASPIRE, that's the one that actually showed 27% efficacy, and the results were announced at the CROI meeting recently. And the RING study showed 31%. And I think the next slide, one of the next slides will just show you exactly, a little more detail of those studies. And then that's the Caprisa 004 here at 39%. And then comes, the pre-exposure prophylaxis, studies using antiretroviral therapy. And you can see that actually there's one which was looking at treating, discordant couples, where we know for a fact that if somebody is HIV infected and they've got a partner who is negative, if those partners, firstly, if you treat the infected partner and also put the non-infected partner onto PrEP, you definitely reduce transmission significantly. In fact, one study, had an efficacy of as high as, more than 95%, 98%. So, which therefore means we know that treatment for the infected and PrEP for the partner will work, and it will definitely reduce HIV transmission to the uninfected partner. So this just shows you that, these are some of the studies that we have seen. So when we're using antiretroviral therapy, antiretroviral, as a part of prevention, we have seen significant effects. But the question that always comes up is this sustainable? Firstly, are patients or are the participants going to be taking these drugs? Because it's going to mean, if you know that you're at high risk and then you come for PrEP, then that means you've got to take treatment for the rest. You've got to take prophylaxis every day for your life. And whether that's sustainable or not is a different, is another debate that we need to look at. Which is why, whilst PrEP, PEP, treatment as prevention works, and it needs to go ahead, and we support that, we do need to make sure that we come up with a vaccine so that we can use a vaccine run. Now, what I was saying earlier on, we only see efficacy when people take their drugs. If they don't, we will not see efficacy. So this just shows that the lower the uptake, the lower is the effectiveness. Whereas for those that are actually, the uptake is quite high, then we see definite reductions in transmission. This just takes us through. I know it's very, very busy, but I thought I kind of like it in that it summarizes, all the medical, biomedical prevention methods that are, that are in the pipeline, what people are doing, So, there's, well, we've talked about the vaginal gel. There's the vaginal ring, the results that we have now already. Then people are looking at long-acting injectables as PrEP, because as an alternative to either the gel or to a ring that patients can take, in and out. So a long, acting injectable would be great. And then we've talked about oral PrEP, and then prevention, HIV vaccines for prevention. And then, like I was talking about, these broadly neutralizing, antibodies, whether they can be taken, into some of the, vaccine constructs, and then we see. So there are studies that are going to be looking at that. So there's a lot that is really, happening, and hopefully we're going to improve, each day. So where are we, therefore? Just to summarize. So male circumcision, we know it works, and it works well, and it has been rolled out in our country, and we know we will see the results thereof. As I have mentioned, HEART is actually is great for prevention, whether it, especially because then it reduces the viral load and therefore renders the infected less transmissible, less at risk for transmission. Mother-to-child transmission, I've mentioned this already. We're now sitting at percentages that are below, that are close to 1, if not below in some, in some areas. So PMTCT has been very effective, and it works very well. This works provided it's, they are used, as I have said, already. And then treatment of STIs. Now, STIs are always, like we said, there's limited evidence, because there has not been a study that has, except for one that was a long time ago, the Rakai study, which actually showed that if you were to treat everybody for STIs, then there will be reduction of HIV acquisition. We have not managed to duplicate that study, but we know for a fact that STIs, like for instance, genital ulcers or discharges, they actually increase the risk of acquisition of HIV acquisition. And therefore, it just makes sense that you need to make sure that you screen people for STIs and you treat them, because otherwise we know STIs cause inflammation, and we've already said that in any inflammatory process, in the genital area, will increase the risk of HIV acquisition to those who are, are uninfected. I've already talked about microbicides. That really the best that we have had so far was at 39%. Now we've just had these results, like I was saying. So there was the vaginal ring. These were actually run by two organizations, the IPM and NTM, yes, and the NTM. And so overall, 31% and 27% efficacy. But when they then further analyzed the data, they realized that actually, if they took out everybody who was below 21 years, so it was 18 to 21. If they take those young, patients out, then the efficacy improved, especially for the IPM study, the ring, to 56%, and for the dapivirine, it went up to 37. And what they did here, they actually looked, they monitored whether people were using the ring or not, in that they took blood samples to measure the amount of the drug that was there, and they actually made sure that every participant brought back the ring, and they looked at the drug concentration on the ring after use to determine whether it was, it was truly used or not. And when they did that, they were able to show that those that actually had used the ring, in other words, whose concentration of the drug level was low, below a certain figure, those actually, the efficacy even improved in those ones, which goes back to what we were saying. People have got to use whatever mode of prevention for it to be effective. And I've already mentioned, about the HIV vaccine. That is still quite a while. Now, we have said young women are an issue. And in fact, so even in the ring, vaginal ring studies that results have just come out, it shows that the adolescents are not, they kept on taking their rings out. And the question becomes, how then are we going to, to actually address this? Because we know that they at the same time carry the bulk of the infections. And we know that actually the abstinence, they're already sexually active. For me, I believe if you want to teach abstinence to everybody, because I am a strong believer of abstinence, but we've got to teach them as they grow up. You can't teach an 18-year-old who's sexually active to abstain. There's a lot, it would take you a lot more energy to get to that level. But if you teach them young, maybe we would succeed. But we know that actually with the current, pregnancy rates, that we know that young people are sexually active. Being faithful, yes, you can be faithful, but is your partner faithful or not? Faithfulness has really got nothing to do with you as an individual, but it takes two to tango. So that really does not work. Condoms, for a long time, when we talk condoms, we've been really talking male condoms. And we know, the disparities that are there between the sexes. And so it becomes a problem whether some of these young girls can negotiate condom use with their partners. Now, the pills and the gel, we have seen the results in that these young girls are not taking these pills and they're not taking the gel. And in fact, now, even the ring, it means they are not actually inserting the gel as they should, the ring as they should. The recent results have that shown. Now, people have tried, to be innovative. There's this whole concept of cash incentives. Can it work? Maybe because some of the stories with these older male partners, in young girls is usually, well, because he buys me, airtime, he does this for me, he does that for me. So maybe can we design a study that's gonna do something similar, just to keep the girls at school and keep them away from the older men because that's where they're getting the infections from. So just looking at cash incentives, and there's a slide that I got, amongst the slides I got from Croatia that just shows some of the work that they have done, where when they looked at grade 9s and 10s and they had given them, there were conditional cash incentives given to these girls. There were so few HIV infections that they really could not, they couldn't, measure, those balls. There were just very few outcomes. But the closest to that was that when they looked at HSV2, because we know the link and the synergy between HSV2 and HIV1, it showed that those who were actually in the intervention group, there was a reduction in HIV acquisition. So maybe that's something that we need to explore further. I'm not, well, now this is me personally, the cash incentives need a lot of discussion and, ethical issues. So we would need to just make sure that when we design those studies, they are very well designed. I'll come back to you just now. Let me finish. Okay. And then, so really, when we're looking at prevention, there are multiple approaches to prevention, and we need to integrate, the prevention to care and treatment. And I think this is where Steve's talk comes in, because otherwise, we definitely have got to move away from this streamlining where you've got just an HIV clinic, an antiretroviral rollout clinic, you've got a TB clinic, you've got the general, non-communicable diseases. But it all needs to be brought under one roof, and prevention must be a part of that, brought into care and treatment. And we know that any integration is definitely going to be overwhelming, and actually it calls into ensuring that the health systems are strengthened, because it otherwise is critical for the integration, So what have we achieved? This is my second last slide. Access to therapy, we have done very well even as a country. We've got the highest number of people that are on treatment. And as we've mentioned, mother-to-child transmission has come down to, very low. And we know that antiretroviral drugs actually prevent HIV infection. So whether they are used to reduce the viral load in the infected, or they're actually used as prophylaxis to those that are not infected, we have seen the results thereof, which therefore means we do now have got better tools for prevention. What are the challenges? If we say condoms work, then how do we increase the uptake of condoms? And I don't think we've got this one correct, and I don't know how. That is why it becomes important that especially the social researchers to actually come into this. What is really the issue? Why is it that knowledge does not translate into modifying of the behavior? Adherence is a huge problem. Now, adherence is to any prevention package. in fact, is the same that we're going to be struggling with even with treatment as prevention. Because if patients don't take their antiretroviral therapy, then they're not going to maintain the viral suppression. And as I have mentioned, you know, the HIV vaccine at the end of the day is going to be what we need. Thank you very much.